Hi, everybody, and welcome to the August Lipedema Patient Roundtable. A lot of people say it's the best night of the month, and the reason why, well, first of all, you're here. Thank you for giving us your time this evening. Let us know you're here in chat. We love engaging with our audience. Chat is always on fire. We know you're going to have a lot of questions for our panelists and for our special guests. And without further ado, I'm just going to do a quick run around the round table. Jenny Bogine of Lipedema and Food Sensitivities, Patty Cornute, Lipedema Fitness, Pale Ginger Pear, the lovely star of screen and stage. I don't know, you just look especially star-like tonight. Angelique Charles, the Lippy Butterfly, who got published on HuffPost since we last got together. We need to talk about that. Linda Ann Kahn, one of our clinical experts, who we only have her for a half hour tonight, and we want to talk about estrogen and lipedema with her. And our special guest tonight, direct from Beverly Hills, California, Dr. David Amron. We're so honored to have you with us.
Thank you. Thank you so much.
So we've got a lot to talk about. Laura's here from St. Louis, Amanda from Surprise, Arizona. We've got Michigan, we've got North Carolina, we've got lots of North Carolina, and we've only just begun. So without further ado, I want to first go to you, Dr. Amron. We had some questions populated before we even went live. And one was, you are a dermatologic surgeon.
Yes.
What is different to your approach to lipedema surgery from, say, a plastic surgeon?
Yeah, so I'll try to be, brief about it. So, it goes back to just liposuction in general in terms of the different approaches to it. In the US, currently the main groups doing liposuction are plastic surgeons and dermatologic surgeons. I would say there definitely are more plastic surgeons currently than dermatologic surgeons. Some other groups, certainly do it and can do it. The general approach it's really quite different, and it has to do primarily with the anesthetic approach. We generally will approach things doing it under what's called tumescent anesthesia and generally avoiding general anesthesia. And the credit for that has to go to a person who's in between myself and Linda Ann Kahn geographically, a guy named Jeff Klein, who's a derm surgeon like myself that developed tumescent liposuction in 1985. And so it's kind of in our area, that way of doing it, whereas plastic surgeons will generally do it under general anesthesia. And there are differences. I think there are advantages of avoiding general anesthesia, and it generally falls in three categories, one being safety. And that's been shown by a lot of studies to be a safer approach. It's really a cleaner approach by preparing the area properly and completely. And then patient positioning, which is a huge thing, especially when you're doing a lot of these complicated areas, to optimize that. And it just tends to be cleaner. It forces the surgeon to stay in what I call the safe plane. That's another thing too. So, that's kind of a complete but brief answer to it.
Thank you so much for that. I know that does answer a lot of people's questions out there. And before we went live, you mentioned something that can be a hot button issue. And by the way, if our viewers tonight have questions, put them in the Q&A. This is your big chance to talk to Dr. Amron, Linda Ann Kahn, and any of our panelists. We'd love to hear from you. You talked about incisional drainage. Let's go there. And I know, Linda Ann, you may have some thoughts on that as well.
You want me to start?
Yeah.
Okay. This has been a very hot topic. I think about the last month, and let's just put it on the table, because like I've said, listen, we're all in this as a team, hopefully in the best care of all of our patients. That's what it's all about. And so this is going to take a few minutes. I'll try to be succinct and brief. So what we're referring to is a post that was put up by one of the patients, Ashley, who I have a lot of respect for in terms of increasing awareness. We did surgery on her, a couple surgeries in the post-care, the day after surgery, where it was shown in my center that Pearl, my lymphatic therapist, was doing a more complete, more aggressive, I could use the term, type of decongestion, where you're actually really moving the fluid out from the surgery the day before. And it's a little more graphic, more bloody fluid is coming out. And that post was put up, and I think it stirred up a whole bunch of different things. And it fell into different areas. And Linda and I communicated about this, and we're going to communicate more about this. And she brings up a lot of very good points too. And I think we're both trying to understand the two areas and what should be done. So let's talk about that for a second. So the reason why I changed my protocol about a year ago was there were a number of patients I was seeing that became very congested after surgery. I think Linda's seen that, where I call them the delayed decongestors. They go into a firmer place of congestion. And it wasn't always your very advanced patients like stage 3 or stage 4. Sometimes it happened with a stage 1 patient. And I think what was going on, and I actually really do think this is going on, is when you're doing liposuction, you're releasing a lot of fibrotic tissue and the fat. That tissue is very inflammatory, okay? And it's sitting around there increases the degree of post-surgical inflammation, and that can lead to more congestion, and people have an exuberant inflammatory response. So I and Pearl thought of moving that fluid on in a more complete way, other than just typical MLD, and moving that out. And we're finding that we're getting a lot less delayed decongestion with it. And I do think it is a useful thing to do. Now, subsequently, I've heard that that's also being done in Germany, and I'm not the first person to think of this thing to do. I want to clarify a few things. It's not MLD therapy, and I agree with that. It should not be called MLD therapy. It is post-surgical decongestion. Maybe the word incisional drainage is a good term. I just hate that term being confused with incision and drainage, which is really a surgical procedure that should be done by a doctor. I don't think it is damaging lymphatics. I actually think it helps move the fluid along that is stagnant, that could be a setup for infection. I do think if it's done, it should be done in a medical surgical facility and not just outside of that facility. So it shouldn't be done typically as part of MLD therapy. I do think who's doing it is now the final crux of things. Who should be doing that? And this is a real discussion. And this is where I really want to put things on the table. I think that lymphatic therapists, who I have a lot of respect for, have gone through a lot of training, and there's many schools of thought with it, is something that generally is not taught, or maybe not taught at all, in lymphatic therapy programs. Am I right, Lynn-Ann? Yeah.
Post-surgical care you're talking about, yeah.
Yeah, in the care of my patients post-surgically, which I have the responsibility for, when somebody is doing something that's an employee of mine in my surgical center, especially on post-operative day 1, whether it's a medical assistant or a nurse practitioner or another assistant, who should be doing that thing? Can it be a lymphatic therapist under my direction that's doing it? And this is where this whole thing comes in. With New Jersey and Florida and it being outlawed, or I don't think it is illegal in California to do that, especially in my center with it. Is it something that should not be or cannot be done by lymphatic therapists under my supervision or direction with it? And listen, I don't want anybody to get in trouble, including myself, nor certainly Pearl, my therapist, with things too. So I have to abide by laws and rules with things. But is this a gray area, or is it a black and white area? If it's a black and white area, I'm going to stop to do it. If it's a gray area, I want to continue to do it because I really truly believe in it. I think it prepares the tissue better for the MLD therapist who are handing the patient off to in a cleaner way. We're seeing less delayed decongestion with it. If somebody is referring a patient and they don't want it done, or the patient doesn't want it done, we don't do it with it. But we'll just go back to the old way in which we used to do typical MLD therapy on patients day after, or possibly bandage them. So that's a long answer to a very,
I know. I sort of dropped a bomb on you right to start off the roundtable.
I said we should talk about this. I didn't think we'd be talking about this. I was trying to warm up a little bit here, but let's get into
we just went for it, and we appreciate your answer. And I think I should say this because I see a lot of new names in our attendee list tonight, and we are so honored that you're here. I have a feeling, Dr. Amron, your name was quite a draw for our audience tonight. And for that, we're grateful, because we're all, like you said, on the same page. We want to lift up the lipedema community. We want to raise awareness. We want to answer questions. And on this forum, we do not say that what might work for Angelique or what's going to work for Pale Ginger Pear is necessarily going to work for Linda Ann or Patty or myself or Jenny. We don't say surgery is the way.
Right.
We don't, it's so individual. And I think there are already so many questions coming in, and I do want to get to the other hot button issues on the panel, but go for it, Dr. Amron.
I just have one more thing in regards to that, and I'm so sorry. Listen, a lot of what I've done in my career, and I wrote this to Linda, and I think she knows that. I've advanced a lot of things. I mean, let's go back. I mean, calves and ankles should never be done with it. It's too dangerous from compartment syndrome or DVTs. Even years ago, I think liposuction was, had skepticism in terms of lipedema itself, be concerned about that, which has now become somewhat much more accepted. 5 liters of fat, which is more of a guideline, but even my societies, oh, you can't do that, which I challenged that. BMI indexes, I talked about that in Cleveland last year and stood firm about my stance about BMI indexes as a archaic way of looking at things, and now we're beginning to see, you know what, I was right about that thing with it. So many things I've challenged, the norm of with it. And is this another area that maybe we should look at and challenge some of the ways we are doing things in the advancing care of our patients?
I love that question. And I think everybody on this panel would say, yes, let's keep pushing the envelope. Let's keep asking the questions, even the uncomfortable ones. And let's keep having disagreements, because somewhere when we land, we're going to come on answers that move this topic forward. And that's all we care about, is getting answers for patients. And speaking of which, Linda Ann, you've been doing a deep dive into a topic. We know that lipedema is often triggered at hormonal junctures. You've been doing a deep dive into estrogen. What are you learning that we can learn from you?
Well, I found about 4 or 5 studies on how estrogen affects we know that during menopause, during all hormonal changes, pregnancy, that our patients will flare up. And often patients, it will only be during menopause. But now there are studies showing that estrogen dysfunction may actually be central to the development of lipedema. It's a potential hormonal therapy. Estrogen is connected with inflammation, with adipogenesis. So it's very, very interesting how this is all coming out. And one of my colleagues, who is a lymphedema therapist, and I actually diagnosed her at a national lymphedema conference about 20 years ago. Dr. Herbst and I had just given a talk, and she came up to me. She couldn't do anything with her lipedema. She had lipedema stage 2, and nothing would work on her. And she listened to Dr. Amata at one of the conferences where he spoke about having nutrition first, reducing the inflammation, and then doing surgery if needed. And so what she did, she went to a naturopath. She checked all her hormones. They were totally out of balance. She was just premenopausal. She balanced all the hormones. She balanced the liver, detoxified the liver, which also estrogen is stored there. She's lost over 40 pounds now. And when I saw her at the conference, the FDRS, I couldn't believe it. I mean, she's lost, since then. Unbelievable. So we know that estrogen is playing a part. And somebody asked me the other day, is there a cure for lipedema? And I said, how can we have a cure when we really don't even know what the cause is? So we know so much, but yet we know so little. And there are all these studies. I can put them in the chat if you want, but Sarah Al-Gadban is doing a lot of studies. She actually presented at FDRS. There's a foreword of a book that she wrote that's an open access. It's called Estrogen as a Contributing Factor to the Development of Lipedema. So It's very, very exciting with the estrogen receptors. the alpha and the beta receptors. But can I say something about Dr. Amaron?
Of course.
Okay, so I've known this man for many, many years. He is amazing. I've worked on many of his patients. I refer patients to him. I work on his patients, and I think he's amazing. And I saw that video, and I was like, oh my God. And so I had to talk to him because I know him, I love him, I respect him. So what we've had lots of communication back and forth. The main thing is, and Dr. Amaron said this, it just shouldn't be called MLD. If it's a post-surgical technique that Dr. Amaron is doing in his office and is getting good results with that, that's fine. But I think what happened in this video, it was called MLD. And the problem that we MLD therapists have had, universally, it's been posted on some of our boards for a few years. Patients are coming back from Brazil and the Dominican Republic, and they're having actually a syringe put in, and then they have everything squeezed out of the sutures. 2, 3, 4 days later, patients come to us and want us to do that and tell us we're not doing a proper job. Mm-hmm. So that's why it stirred such a flurry. And
now it makes sense. I mean, it took me a while to kind of understand what is the crux, what is this about, but now I truly understand, Linda Ann, and so I'm sorry that that was being called MLD. I understand. I also understand the position you're being put in by other patients, expecting you to do something that's really not proper to be done. First of all, outside of a medical center, and also by you. And so, yeah. Yep.
Lots of good topics here. We've got lots of questions going on, but I want to first go to our panel. Go ahead. Yeah.
I'm so sorry. I mean, I just.
No. Okay, here's don't be sorry. We have you for tonight. So
I don't know. I don't know the rules here yet. So I'm trying to still
our rules are
learn proper podcast etiquette. But with Linda, the estrogen thing, it really is so interesting. It's right in front of our faces. Obviously we see that it plays a significant role. Puberty, menopause, hormonal changes, it picks up an activity with things like that. Why men who are carrying the gene, as we know, as frequently as women, because I definitely think it's autosomal dominant, rarely show signs of it. Although I got to tell you, I'm seeing more and more men coming into me with actually signs of lipedema because they're carrying the gene with it. Usually those men do also have estrogen imbalances. And so, it brings that about. I'm going to tell you another interesting anecdote. I had a patient that I'm communicating with her oncologist in New York now who has breast cancer that is very estrogen dependent, the breast cancer. And she also has lipedema, and her oncologist wants me to move ahead with lipedema surgeries on her with it. Even though she has currently breast cancer with it, I'm wrestling with this patient that has cancer, has an estrogen sensitive cancer, and trying to understand the role of lipedema surgery. And I'm going to tell you my thoughts about it. And this is something really interesting. And I've said this, and this, fat is a very hormonally active substrate. It almost is an organ by itself endocrinologically. It's not only responding to hormones, but it is producing hormones. And I think one is also estrogen the fat is producing too. And by removing a lot of lipedema fats, how that might impact this patient's cancer who is being made worse by estrogen. Do you follow me with that?
Yes.
So, it's a really interesting area, this whole area of how the estrogen is playing with the lipedema.
And we are hearing a lot in chat about women that are going through perimenopause, and it's just exasperated things. We'll get back to this topic. I don't think we're done with estrogen for the evening, but I do. And Angelique, you are shaking your head. You're right. We are not done with it. But I have to say, we are all in awe of what you accomplished over this past month. Unmute yourself. We want to hear about how your article hit Huffington Post and is raising awareness about lipedema all over the world. Congratulations, Angelique Lippy Butterfly. We are so proud of you. Tell us how this happened. Tell us how people can find the article and have at it. We're so proud.
Thank
Right.
you so much. I have to give a big thanks to the Lipedema Foundation for helping me to get that article out to the Huffington Post, as well as being able to be on Black Health 365's podcast. These are like really big things because I really want to tap into the Black community, which I think they are very underrepresented in our lipedema community. I also keep saying I really think that that percentage will go up if we have women who are Black presenting with their symptoms, because there's a lot of Black women who shy away from, actually explaining what's going on with their body. So it was really important for me to give a really realistic view of what was going on with me and the challenges that I had to overcome in just getting to a diagnosis. It's not, the article and the interview aren't meant to like give any big tips or anything like that. It's really to say, if you're experiencing pain in your fat and things like this, there might be something going on with your body. And there are professionals out there like Linda Ancon and Dr. Amron who have the potential to help you, as well as groups like the Lipedema Fitness that actually give information that can help, So the whole thing is to just try to get people who aren't inside of our community to know if they're experiencing symptoms. There might be an answer for you.
Well, it was such an amazing splash of candid, heartfelt, beautiful information. You are an amazing spokesperson, and we're just really proud that you're on our panel always. And we love your story. And folks, what we'll do is we'll send you the link to that article if you missed it. But if you must have been under a rock, because it was everywhere in the last few weeks, which is amazing. Also, I saw you, Pale Ginger Pear. You were bouncing up and down. You were surprised. Pale Ginger Pear was on the rebound. What was up with that?
So I've been using a rebounder for like 3.5 months every day now, which anybody who has talked to me or looked at my stuff for a while now knows that I was very like anti-forced exercise from like past childhood trauma, which sounds dumb, but it's very much a real thing. And I had a struggle finding movement that I enjoyed other than swimming, which in Pennsylvania, I only have a few short months that I can actually swim. So I was struggling with something that I enjoyed and would continue to do. And I came across, or actually Bellicon reached out to me and was like, we think this would be really good for you. We would love for you to try it. And I was like, okay, sure, why not? And I absolutely love it. I use it for a half hour every single day, sometimes more, but at least a half hour. I do 10 minutes in the morning, 10 at lunch, and then 10 at the end of the day to like help move my lymphatics, especially because today I worked an 11-hour shift. I was sitting for a good chunk of the day.
You do not look like you worked an 11-hour day. I am impressed, but I love how you are always trying out new tools to manage the lipedema. And, this is what we talk about here. We talk about everything. And usually, do you have to go to the bathroom afterward?
So at first it was one of those, like I would start to bounce and be like, ooh. So now I make sure I go before I get on it, just so I don't have to stop. But it does move the lymphatics. I can tolerate longer times now being on it before I have to rush. But yeah, I notice my legs are stronger. I can stand longer. My wonky, like hypermobile knee doesn't go out as often and does not hurt anymore. I have less stiffness and firmness in my thighs where like the fluid wanted to still kind of hang on. They're soft and jiggly now. I can notice the loose skin from surgery, which I'm not 100% thrilled about, but like I can see these changes. So I know I'm getting like the stagnant like lymph fluid up and out. And it's been a great and surprising, and I'm seeing like a definition to my legs and a little bit to the booty, which didn't really have a curve before.
Which, by the way, we're all seeing too. It's noticeable.
Okay, I'm glad it's not just me.
No, it's not just you. And what's your go-to song to rebound to?
Oh, so I vary, but a lot of times I tend to go to like 90s, early 2000s R&B. Like they
Mm.
just have a beat you can bounce to. Like Nelly, for some reason, is really great to bounce to.
Okay.
Of course,
Well, if it's getting hot in here, but we're
I
not
mean-
going to advocate that you guys all
Yeah,
disrupt,
and
because
of
this
course-
is a family roundtable, Dr. Amron. We are
Hey.
PG rated. Absolutely. I also want to go to you, Patty, because you showed us how you use a yoga strap. Tell
Yep.
us about that.
I am a big fan of doing yoga, lymphatic yoga, and some of the poses that are kind of in that realm to help move stuff are really hard for a lipedema shape to kind of get into. We kind of struggle with just the shape of our legs. And so a yoga strap can be used to help you. It kind of gives you an extension. So you don't have to be as close or have your arms holding your legs if you're kind of using the strap to hold your leg in position better. It's great for stretching, but it's also really good for elevating your legs. So if you need to elevate your legs, which we talk about doing like on the headboard and whatnot, it's a really great tool to help you do it without injury because it's very supportive. So it supports your joints if we're hypermobile, and it can help you hold the position longer. And the really important thing is getting into the position without being concerned and bracing for the pain. When you're bracing for something to hurt, it means you're tensing your muscles and it doesn't allow the movement of the yoga pose to do what it's supposed to be doing. So
wow, that is really, really good. Now, we know we're losing you, Linda Ann, in 4 minutes. So I want to go to a question about estrogen dysfunction and what you mean by that. But before I do that, Jenny, you do not a yoga strap, but something similar?
Yeah, absolutely. My physical therapist about 8 years ago, which was long before my lipedema diagnosis, actually encouraged me to get a stretch out strap. He called it same thing as a yoga strap, but it absolutely helped me be able to do things with my legs that I couldn't do otherwise because of the muscle structure and problems there, and to be safe in doing it. But I even, when I have leg problems, I could even use it to lift my leg in and out of the car,
Yep.
So I'm all about adapt and move on. So I take that puppy with me everywhere. It's also something easy to travel with to keep up doing exercises and things.
You take that puppy, but I bet Mittens doesn't like that because Mittens, your
No.
kid, does not like
No,
a puppy.
would not.
So Linda Ann, final words. I know you've seen a lot of the Q&A about estrogen here before we lose you, because you are very busy lady and you're headed to another presentation. When you say estrogen dysfunction, what do you mean? High, low, out of balance with other hormones, a specific type of estrogen?
Well, there's estradiol, estrone, and estrol. And so those can be out of balance, and then the testosterone can be out of balance. For example, I do have a patient who's a male. He's actually moved out of state now, but he has classic lipedema. And just like I think Dr. Amron said, he has very, very low testosterone. And I found that the patients who are male with lipedema usually have no testosterone, but his estrogen is really high. So that's it's dysfunctional, it's out of balance, and he actually has gynecomastia.
Really?
Yes.
Wow. And by the way, the book that you mentioned on estrogen and lipedema, what is that book? Denise Jones.
Okay, I put it in the chat. It's actually from a chapter, it's a peer-reviewed chapter, Estrogen as a Contributing Factor to the Development of Lipedema, and it was written by Sarah Al-Gadban.
Right.
Okay.
And it was reviewed in February 2021.
Thank you so much. And will anything like surgery affect a woman in menopause and her hormone levels? Will they drop? Valerie Mills is asking a multi-layered question. Going on natural hormones to help stop UTIs, will surgery be undone with hormonal flux? Maybe that's a question for you, Dr. Amron, or in concert with Linda Ann.
Will surgery be undone by, so I understand. So if you do surgery and you go through a hormonal fluctuation, will the benefits of surgery be undone? I mean, it's a great question. So yeah, I mean, this comes up a lot, and it has to do with, another way of asking it is, should I do my surgeries before any hormonal fluctuation? either pregnancy, should I wait to have kids, and then do surgery, do it before, or menopause or whatever. So this is what I've seen. We know that hormonal fluctuations will tend to increase lipedema activity. It's not causing the development of lipedema. So I just want to change that word development, but it's showing it up more. It's increasing activity. So you're going to see it in men. It's going to increase. So if you do surgery, and you get an amazing result, life-changing thing, and all that stuff. If you go through menopause or pregnancy, will it undo it? So this is my experience with it. In most patients, it doesn't. And I would say probably the vast majority of patients, it doesn't. Now, why is that? Because, and I actually had a few patients who I did surgery on that became pregnant after that, and there was no flare of their lipedema. But they showed me pictures beforehand when they had pregnancies and it flared up with it. I think a lot of it is because you removed all that substrate that is waiting for the hormonal changes to start either becoming mitotically active, those cells, more swelling, more inflammation, more of the process. So when you remove that substrate before the hormonal fluctuation and you've decongested things in a proper way, it tends to not flare with pregnancy or menopause or other hormonal fluctuations. Now, the key word is tends. I'm not going to say it's guaranteed, but generally it's not going to happen with it.
I see PGP.
Linda Ann, any thoughts about that or what you've seen?
So
Well, yes.
Linda Ann and PGP, go for it.
Okay, so, did I?
No, you're there. We hear you.
I'm unmuted. Okay. So I had one patient who had a flare-up of lipedema. It created the lipedema during pregnancy. So she was terrified. She then became pregnant again. Unfortunately, she lost the baby, but she was so frightened. And I just said to her, there's not a reason not to have a child.
I agree.
And I have another patient who I saw about 7 years ago. She had one surgery. She was really, really large, almost stage 4. And I didn't see her for many years. I followed her on Facebook. She'd lost quite a lot of weight. Turned out she had gastric bypass. She's come in. She still has lipedema legs, but she's had a baby now. She came in to see me while she was pregnant because she wanted me to help her with the fluids. She's had a baby. She's doing fantastically.
Oh, that's a
Yeah,
great
I think it's a really great point. I know Linda Ann's going to go, but along those lines, I tell patients, at least before pregnancy, like if they're planning on having a kid soon, like have your child. Don't delay it because you're afraid about getting, we'll deal with it. Linda Ann will do her magic to prevent it from getting worse with things like that, and then we'll do surgeries after. Like, do not delay having a kid just because you're afraid about things flaring up with it. Now, menopause is a little bit different. I guess if you have a choice about doing it before or after, it's probably better to do it before menopause, before the hormonal changes, if there's a choice with it.
Okay, Kara, go for it.
So I also think that those of us who have had surgery and have a better understanding of what to look for, we are doing a lot more like maintenance work on ourselves than we were. Like I knew nothing about lipedema when I had my son. So I wasn't doing anything that would have in terms of compression or watching inflammatories or making sure I moved the fluid. I was doing nothing because I had no idea. Now I know, and I rebound, I'm my pump and I'm my vibration plate and my compression. And I've been watching my inflammatory foods, like I've cut out corn and stuff like that. So that if I were to happen to get pregnant again, or I'm 41, menopause is going to be sneaking up on me before I want it to, I feel I'm more prepared for those hormonal changes. If I would start to see regrowth, that I can catch it quicker because I know what to look for now. And I've been doing more maintenance versus before when I knew nothing and had no reason or no explanation as to why my body was reacting how it was reacting.
That's a really great point. I mean, what I call pale ginger, pear ginger, what I call it? Sierra? Okay.
Sure, yeah, I mean,
No, I mean, that's a great point. Listen, I mean, surgery or not, I mean, everybody should do whatever they can to slow the progression of lipedema. And even after surgery, there's a responsibility to everything you can to combat this condition. And those things fall into primarily two categories: dietary respectfulness for lipedema. And I don't want to get into all the nuances of, you know, whether it's a RAD diet or variations of keto, but that's one thing. Number two is proper congestive, respectful stuff. Now, whether it's rebound or continued garments or pump therapy or whatever it is, but people fall into different categories with it. I will say that. So, you know, I get asked this a lot, you know, with swelling after surgery. You know, you do the surgeries, you do a great job at it. People fall into three categories. It's a really good way of looking at it. Category one, people just don't have a lot of swelling after surgery. You know, that it's kind of like done a great job of also reducing swelling. Category two, they still swell at certain times. They should always be respectful and pay attention to it. And category three are the aggressive swellers who will continue to swell even after the best of surgeries because they have a lot of leakiness or lymphatics. Those people need to be very rigorous with their compression protocols after surgery, because I hate to see it, those are the ones that are at a slight risk of return of the lipedema. And doesn't that make sense? Because if they're swelling, that's the first thing you got to pay attention to. That's the first process that's going on with lipedema, the swelling. Then you get the development of the fat, the inflammation, the fibrosis, the vicious cycle. So you got to prevent the swelling. And if people, even after surgery, are swelling, you got to pay attention to that. If they're aggressively swelling, be aggressive with it. If they're not swelling at all, okay, great. I mean, maybe don't be so as, you know, on top of it. And that's a really good way to look at it. So you always have the responsibility before and after surgeries, paying attention to diet and compression stuff.
Excellent. And of course, Lympha Press is the host of
I
this
forgot.
monthly roundtable, and we have seen wonderful results pre-op, post-op, regular management of your lipedema and lymphedema. And if anybody out there watching wants to know more about what Lympha Press can do to help manage your lipedema, please visit our website, lymphapress.com. We would be honored to help you.
I'm gonna give a very nice plug to this. I'm sorry, but I'm gonna give a very nice plug to the importance of compression pump therapy. You know, I used to reserve it and only write it for patients that are more advanced patients, or patients I think that are really going to maybe need it for sure after their surgery, but I don't do that anymore. I actually write it, and we try to battle for every patient to get it covered, because you know what? I really do believe in it. And I really believe in it, especially after surgery, in every patient after a period of time. And you can't pick and choose which ones are maybe going to be in a bad place and need it. So I think compression pump therapy is a very important thing. And certainly even before surgery too.
Yeah, I appreciate you saying that. And many of our panelists have experienced it firsthand, and they can say it made my life better. And that's what makes my life better. It makes me happy to hear that. Okay, lots more questions. I want to get into them because they're really good ones. We love your questions. And by the way, this is currently the best attended live Lipedema Patient Roundtable we have ever had. We are at 111 live attendees.
Wow.
And we appreciate all of you. Thank you so much. We'll get many more on the replay too. Regarding surgery, this is a great generic question. Cynthia Mason, we're so glad you asked it. What are the most important things, Dr. Amron, that patients can do in advance to improve their surgery outcomes, such as pre-surgery MLD, supplements to take or avoid, etc.?
Yeah, you know, it's a very common question. And, you know, listen, primarily I'm a surgeon with things, and I do want to be careful how I answer this. So I don't want to minimize a lot of very important things. But you're asking the question, what can a patient do to prepare prior to surgery? So the way I look at things, I think that you've either got patients who are more advanced with things, who it's very imperative they do things, and the patients that are, you know, less complicated, your milder patients are maybe not very fibrotic with things. I will say that the more advanced patients, let's just say certainly lipolymphedema patients or more congested patients, it's very important for them to get on a pre-compression protocol prior to surgery, okay? To get as much decongestion as possible. The ones that, you're looking at their tissue, because I do a lot of virtual consultations, and you can just see it. I mean, their lower legs are bright red, and you ask them, and they're shiny and woody and hard. I mean, come on, these patients have lipolymphedema. That tissue is not in a healthy place. And even as a consideration to do surgery, you want to make sure that tissue is in a healthy place before anybody goes in to do liposuction on it, because you can have problems in the recovery of things and complications. So on those patients, it's imperative they're on vigorous compression protocols beforehand. Pump therapy, many times bandaging and wrapping, waiting a long time till that tissue gets healthy to then carefully go in with the proper technique, whether it's circumferential or even semi-circumferential. So I triage those patients how I'm doing them. Other patients who are uncomplicated, I don't want to kind of, minimize things. I think it's great for every patient to be on compression stuff, but it's a little less vital for them to be bandaged and wrapped and pump therapy, every night and stuff like that, because they're in a healthy place or tissue. You're going to go and you're going to put a bunch of fluid in, whether it's water-assisted lipo or wet technique or tumescent, and you're going to decongest everything. And I don't think it's the most imperative thing. Is it a nice thing to do? Certainly with it. Okay, so that's, my general take on that, because I don't like unnecessary things for no reasons. Everybody should be on a respectful dietary strategy right away. Right when they hear that lipedema, everybody needs to start aligning themselves with a diet that they can live with, that is respectful of lipedema for the rest of their life, before surgery and after surgery. Absolutely. That's why we got to be teaching pediatricians and OBGYNs diagnosing at an early age, so you're preventing things. Supplements, and that's something that's really on my radar in terms of the important thing of education with this. I mean, why are so many family practitioners and still don't know what lipedema is? And it's craziness.
Agreed.
Yeah, and let's go on with that. Bariatric surgeons and all that stuff, they need to understand it before they're just doing these, they're proper triaging it. Vein therapists, orthopedic doctors need to understand it, diagnosing it. So supplements is a whole nother big area with things like that. I think that, there's a lot of supplements, that are been shown, selenium, butcher's broom, turmeric, and this and that. There's studies starting to come out about some of these things with it. I think that they certainly don't hurt, and it's probably a nice thing to do. Again, not only before surgery, when you're diagnosed, maybe the rest of a person's life with it. Think of it as your daily supplement vitamin program that's a little more directed towards lipedema. Then there's a whole bunch of other things that Linda Ancon and others are better, to talk about in terms of many different lifestyle things. So long answer.
Good answer, though. And I saw you applauding Angelique, especially when he was talking about a diet that is respectful of lipedema. I also really appreciate that you didn't say one specific diet, because again, it's not always one size fits all. And we know that. And we speak about that candidly here. Angelique, did you want to say something about that?
Not necessarily. It was the diet that's respectful of lipedema, but more importantly, when he said getting a hold of the pediatricians and the bariatric surgeons, those are two main areas that I wish that the professionals that I had gone to as a child and before my bariatric surgery, I wish that they had known even just a small smidgen. And I was asking specifically about lymphedema. They told me specifically that it was not possible, even though I have lipolymphedema. And it feels like if we could catch people at a sooner stage, they would not get to my stage. And so I love that he's saying we need to get information to them, because it's ridiculous that we have doctors who are treating people, and a lot of people with this condition, and they're sending them out their door disgusted, frustrated, and without any answers.
I know, pale ginger, you got to say that, but actually say what you're going to say, because I want to be polite and have good etiquette.
Oh, I was waiting. I just wanted Brendan to know. I was just going to say, I very much agree. We need it early on. We need to do it. I make sure I talk to my friends that have daughters and point out, like, this is what I looked like as a teen, start to notice it. It's not just softball legs, like what I was always told, I look like a softball player kind of thing. But also for those of the listeners, it's not necessarily a diet to lose weight. It's just a diet that won't feed the lipedema.
Yeah.
So because I know there's so many, especially us later stages, that I've heard our whole life to just diet and exercise and lose the weight, and it's not going to happen. So I don't want somebody to get frustrated thinking, oh, here we're hearing it again. It's a lifestyle or a food style that's not going to feed the lipedema so that you feel better. If you don't lose a pound on it, it doesn't matter as long as your inflammation and your pain helps.
That's exactly right. You're right about that. You're right. A few things. So listen, 90% of the patients I consult with every day are basically self-diagnosing themselves. I'm just confirming the diagnosis. The first question I ask patients and those who've done consultations, how did you ever hear the term lipedema and when was that? And their answer almost always is, on the internet, things were not making sense. I was searching painful legs or whatever it is. I came across it. Only about 10% are getting diagnosed by healthcare professionals. That's crazy. And that has got to change. So every time any of us have an opportunity to educate, especially a doctor, about it, scream and shout about it. I mean, just mention it to them. And I've said this, yes, we should be teaching doctors, OBGYNs, pediatricians, and family practitioners, internal medicine doctors. It should be a screening thing. It should be screened. When you've got a teenage girl, age 13, 14, 15, the teenagers, there should be a screening for it. This condition is 10% of the population. It's not that uncommon. We are screening for much less common conditions. Why are we not screening for it? It's your presentation clinically, it's potential symptoms of swelling and pain and easy bruisability and Ehlers-Danlos stuff, and it's a family history that you just look back at with it. Bingo, it's lipedema. Diagnose it, start preventative measures with dietary stuff, teaching girls how to eat, avoiding things, possible compression stuff, and get them to avoid eating disorders and stuff like that, that they get wrapped up with their whole life with things like that, thinking they just need to lose weight and diet and diet and diet. It's just crazy about this. And then a third of them end up doing bariatric surgery because they're not diagnosed. Again, another missing thing. And a further insult to injury, insurance companies pay for that many times, and we're fighting for lipedema surgery, which is really the wrong diagnosis. That's why I hate BMI indexes. It's a terrible way of looking at people's bodies. It's ridiculous. And it gets patients and doctors into trouble with things. So it's just, this insanity has to change.
There is fire coming out of the computer right now. Chat, they're all saying, drop the mic, Dr. Amron. Jenny, I thought your head was going to nod off. So please share what you were thinking.
I want to know how we get this tool into their hands, because I think doctors don't diagnose this when it's early because they think, oh, you don't look like it, because it's all the late stage look. And I should not have had to wait till I was 59 for a diagnosis, because they just kept saying I was fat. I was lying to them. So yeah, how do we get the tool out there to show them the early stages and the teenagers? Where does that tool get developed? How do we start working on that? Because I would be on board to work on that.
Well, I think Lipedema Foundation is doing a really good job of trying to increase awareness to healthcare providers, but it needs more than that. I'm kind of determined to get on the podium. Listen, I love speaking to FDRS and our society meetings and all that stuff with it in our own group. But, I realize that my greater good is to go on into pediatric conferences where there's thousands of them, their national meetings or OBGYNs, and just introduce them to lipedema with it. And, you've got 500 doctors there or more that hopefully, and it's like how that might change things. So,
yeah.
I'm sort of feeling like, oh, I know we only have about less than 10 minutes left here. I'm wondering, Dr. Amron, could we impose on you to stay a few extra minutes tonight?
Oh, a few extra minutes. I will actually. I thought you were going to invite me back again another time. But
yeah, but while we have you, we've got a lot of questions here, and so I'm going to go quicker, and everybody, I'm going to try and do a better job of bundling questions. There were a few questions about veins. Should veins be closed? If someone has vein problems, how does that impact what you're able to do? Can you talk about veins for us?
Yes, I can. I'll try to be brief. So,
can you give it in 5 words or less?
So, no. Yes. Okay. 5 words. No, not 5. Maybe 35. All right. So this is my thing about veins. So certainly, vein issues are common issues, venous insufficiency, other stuff, varicose veins, separately. Many of them have them anyway. With lipedema, I would say there's probably more of that going on because of the congestion of lipedema. So a lot of lipedema patients have vein issues going on. What I see, and please, this is not out of disrespect for vein doctors because they're fantastic, but many patients, it's kind of missed that their main issues is the lipedema. And many times there's a lot of chasing of diagnostic tests and even therapy for veins when a lot of it primarily is the lipedema. And that's what actually brought up. Lindy McCutcheon in North Carolina, is great because she is able to diagnose and understands the role of lipedema and things and how it plays into it. But I see many patients get wrapped up into constant vein treatments with things, thinking that's the problem, they're swelling and pain. And many times it's not the main problem with the lipedema is. My thoughts about lipedema and veins is I would say in general, and this is something that I realized probably over 10 years ago, you've got all that congestion in there, okay? These patients, many are just, the patient I did, today was rock hard in her fibrosis in her thighs, strangling things. What that is doing, it's increasing the hydrostatic pressure in the tissue and literally strangulating the veins, increasing their pressure with it. So my feelings are the lipedema surgery should ideally be done first, decongest, make the tissue healthier with it, and then later on doing the vein therapy with it. The vein therapy will generally be more successful, will have less complications. I'm dealing with a patient now who had vein therapy prior to with thrombophlebitis because you've decongested first. And that's my way of approaching it. And if it's done properly through messing, you're not getting a lot of bleeding with things. I do patients every day basically with varicose veins, and it's not an issue to prepare the issue properly. So my quick answer is ideally, and I don't think this is a self-serving thing, like, do the surgery and everything. Do the surgery first and then deal with the vein issues later on.
Okay, go ahead. There's more. I know you stopped yourself, Dr. Amron.
Well, I was just going to say, when I've run this by a lot of vascular surgeons, I remember I talked to one in Denver, and this was years ago. He goes, you know what? That makes complete sense to me. That really makes a lot of sense. And it makes a lot of sense to me. And it's not only just makes a lot of sense, it's what I see clinically over and over and over again for years. So, generally my stance is lipedema surgery first, generally vein therapy later. But specifically, I don't know what's going on. If there's major issues with the greater saphenous vein that may need to be dealt with, then it's a discussion about things.
Okay. And we also add this caveat every month as well. We are not in any way offering medical advice to anybody who is logged on. We want to give you some food for thought. Do your own study, have your own medical team helping you out with these matters, but we're raising issues that are on top of mind on any chat group. You can see one question that keeps coming up in chat and in the Q&A is also about weight loss meds. Any opinions on those, Dr. Amron, and their impact on lipedema patients? And I just saw your face do things, but we're all sitting on the edge of our seats.
Yeah, we can go on and on with this stuff because, I put a couple posts up maybe a couple months ago about the GLP-1 agonist and my thoughts about it and I don't want to say position on it, but my thoughts about it. So, and I'll just kind of briefly say that, I think these medications are amazing. I think they're game changers. I think they're just phenomenal in terms of certainly diabetes and then even in weight loss in patients. I think that in general, they're going to do a better job of reducing more so-called normal fat and less the process of what's going on with lipedema, which is a complicated process with leakiness, lymphatics, fibrosis, and all that stuff. I'm sorry that the sun's like shining right on me here.
The sun is always out in California. That's what I've learned.
Yeah. Okay. So this is my thoughts about it because it's a serious topic. So, I think that, what I see in about 90 to 95% of my patients is that they'll lose weight on it, but generally they're going to lose weight primarily where they don't have lipedema, and their lipedema is generally going to improve less. It's almost like any other weight loss strategy with lipedema patients, including even weight loss surgery, which we see also. Patients do weight loss surgery, and this is not so like almost always, it's always. They lose a lot of weight, but their lipedema has generally not improved by nearly the same proportion with things like that. We know that goes on with it. Weight loss medications are generally the same sort of thing. They're going to lose more normal fat where they generally don't have lipedema in their torso, and their areas of lipedema will not improve by the same proportion. And that's what I see in almost all my patients. And my concern is that it is another weight loss strategy that patients are going to spend time doing without the improvement of their lipedema. And I'm concerned about more advanced patients, maybe possibly wasting time or years being on them while their lipedema process is continuing with fibrosis, and they're losing some weight with it, but their lipedema process is increasing. Now, I got some flack back saying, oh, of course he's going to say that because, you know, it's making more patients do surgery, but that was not my goal of why I was saying that. But then people then commented and said, you know what, I actually noticed my pain reduced going on these medications, you know, which I'm saying fantastic, you know, that's great. I don't know why that's going on. Maybe it's because they are taking in less foods or more or less inflammatory foods, and then they would see improvements in it because they're getting on a strategy which is less intake. That would make sense to me. But basically, I'd say that, you know what, if somebody goes on, I don't think there's anything wrong with it. I think that they generally are fairly well tolerated, maybe except, you know, some vomiting or nausea, although we don't have all the research in about things. There's nothing really wrong about it. If someone wants to try it, go ahead with it. I don't think it should really be the replacement of surgery or delaying things in somebody who really needs it. And that's my stance on it. I'm actually, you know, looking how I might incorporate it in my own practice and maybe in patients after surgery, because I don't want to start becoming a weight loss doctor treating all patients with it prior to surgery necessarily, but maybe 6 or 12 months later in those patients that we're not seeing weight loss in, because usually it does happen after the surgeries because you're removing all that metabolically active fat. Most patients will continue to lose weight. In those that are not, maybe then you put them on one of these medications 6 to 12 months after the surgery. And that's,
I appreciate that thoughtful response because it is a hot button issue. I know it's been happening in a lot of the social groups. Patty, would you like to speak to this as well?
Yeah, I'm actually on the other side of the table. I have done a ton of research I think it started in January when I stumbled upon a group that was lipedema and these medications. And I was kind of blown away by it and joined and kind of followed along with what some of these people were going through. And numerous people were having a reduction in pain almost overnight, reduction in the fibrotic nodules. You know, somebody very near and dear to me had a golf ball size nodule on the back of her leg that her therapist couldn't even touch. It was so hard and compacted. And within, I think, a month or two of being on this, her therapist was blown away because not only was it softer, it was shrinking. So I think there is a component of anti-inflammatory and anti-fibrotic somewhere in there, not even talking about the weight loss side, but just to have somebody, it's kind of emotional, to have somebody say every morning they get up and they go to stand up and they have to hold on to something because they're in so much pain because, hello, I look like that. To be on this medication for a very brief amount of time and say, I didn't have pain when I stood up. I didn't have to hold on to something. There's something more there, because that's not just because I've been eating different food or less food or it's slowing down. That's something different. And that's what I'm really trying to dig into and find out more information on.
so I got to go now that Patty and I disagree about things, but no, I'm joking. No, I want to, you know, listen, I'm always, you know, thinking deeply through things and it intrigues me too with it. And I do think there is something there. And listen, maybe every lipedema patient should go out and see how they respond to it. I don't know that percentage, you know, it seems like it's less, but I don't want to diminish any person's improvement with it. So I'd say, you know what, try it. see how you respond to it. I don't know why. It's very interesting to look at it. I think there is something with the inflammation going on there. Are they taking in less of those foods? Maybe. I will also say this, that each person's body responds to inflammation differently. And I allude to that when I talk about the different patterns of fibrosis. This is a really interesting topic. There are different patterns of fibrosis. It's not only just lippy nodules. And I've characterized 4 patterns. And I really believe this is what's going on. There's nodular, there's strandy, there's dense, and those people are prone to lymphedema, and there's granular. The patient I did today, I moved 6 liters on, had not one nodule, but tons of granular and deep. And so the pattern of inflammation matters, as well as the way it kind of plays into pain too, which is also almost like a genetic thing. You'll see like the mother, the daughter, the grandmother will have the same patterns of inflammation and pain. Maybe there is something in these medications that's working in some factor of inflammation that needs to be looked at, that a subset is responding to, or maybe they're all responding to. I don't know, but it is a very interesting area. And I don't want to take away anybody's opportunity to get relief of pain from simply just going on what I think is actually very safe medication with things.
Go ahead, Pale Ginger Pear.
I personally haven't done the medication, but I think if it is working for some lipedema women and giving them some actual weight loss and relief, it could be a good tool to get them to a BMI that then surgeons will work on them if there's a BMI restriction from some surgeons, and it might be safer than having like gastric bypass. Like I would much rather take a pill than cut into an organ if it needs to get me
I think
to a BMI.
So first of all, I think gastric bypass is basically, I'm going to make a very, is a no-no with lipedema patients. Really, I don't support gastric bypass. I think patients should not be just put down that road with things like that. And if here's a medication they can go on to drop something like that, it's different. They're going to lose weight with it in general with it. I think the lipedema, generally is a different process, but here it is. Some patients are improving their symptoms of lipedema. But that, Patty and Sierra, let me ask you, so do you think that I even should be considering putting almost every patient on it who's diagnosed with lipedema that's overweight?
I wouldn't say
to see, because maybe some patients are having such a great response to things like that and should be trying it.
I wouldn't say every patient. I would definitely kind of play it by ear. I know personally, I was offered by Dr. Jamie's office if I wanted to do bypass. And I said that I know that for myself, I don't eat enough that I felt gastric bypass would have been enough. And then after one like real detailed conversation with Jamie, he was like, oh yeah, you don't eat enough. This would have done nothing for you. So it's part of the reason why I haven't tried the medicine. Like I don't eat. I forget to eat a lot of days. It's really bad. But I didn't want to try anything weight loss related before my lipedema surgeries because I personally, as a very stubborn redhead, wanted to show that lipedema surgeries is what my body needed. And after the very first surgery, which was just my lower legs, the front of my lower legs, I was losing weight in other parts of my body that we hadn't even touched yet. And so to me, it was showing that as we removed the inflammation and the diseased tissue, my body was able to process and work properly.
Probably
and
estrogen.
Less pain to move more. So I was able to introduce like movement in general and be more active to burn fat naturally. And so I really wanted to show that like, this is what my body needed. Now it's different for everybody. And if somebody wants it and you can help them get the medicine, great. But I don't know if I would want it forced on me as part of a surgery plan.
Well, I mean, listen, I personally, I really don't want to start prescribing weight loss medicine to every single patient for, so I want to use in very targeted ways, And for me, it's probably going to be post-surgical months later. In your case, though, listen, I don't know. I haven't looked at you. We've met at conferences and stuff like that. But you're judging your body by weight. It's a whole nother thing. But we have to distinguish. Is a lot of what you have going on now, even after the surgery, possibly still a lot of swelling going on, which we talked about before. You might be more of what even Karen Herbst threw out this term to me like 10 years ago, the swellers. Where you're moving a lot of movement, a lot of fluid across those membranes. And that's a whole, more challenging thing to take care of. That's not generally going to respond very well to weight loss or weight loss surgery or even weight loss medications with things because you're moving a lot of fluid, nor necessarily diuretics. That's a whole other topic.
Yeah, I have lymphedema, and I did my left leg worse than my right because of an injury. So I definitely know that I've got like fluid issues. So I keep up with my compression and all of that because I know it's an issue that I'm going to have to deal with. So I definitely keep up on it. But I'm also okay if I don't get tiny. Like I feel better. I have zero pain. And that to me was the goal of surgeries, was zero pain. And so I'm happy with that. If I stay this size, I'm okay with that as well. I just don't want the pain to come back. So like, that's why I'm watching the corn and I'm doing the compression and the swimming and the rebounding and all of that just to keep movement going, to keep the fluid from building back up.
EGP, I appreciate you sharing it and always so candidly, and you're so well spoken about it. I want to go to you, Patty, but I first want to acknowledge that in chat, I'm seeing comments like, I feel so hopeless. And gosh knows, that is really a pervasive feeling in the community. And our mission here at the Roundtable is to never leave you feeling hopeless. So we are going to infuse you with hope before the end of this roundtable. And I want everybody to share something positive and uplifting to our viewers, our listeners before the end. Patty, I'm going to go to you. And then I want to also ask you, Dr. Amron, for any closing words that you would have for our audience before we end on an uplifting note. Go ahead, Patty.
Yeah, the thing that I was going to add is just, in 2022 at the FDRS conference, Kara and I sat with a bunch of stage 3 and 4 women, and it was critical. It was heartbreaking. These women felt like they had no options left. Their BMIs were way beyond ever being seen by a surgeon. They've had gastric bypass and it didn't do what they were. And they're like literally asking us, so what do we do? Wait to die. Yeah. So if something like this type of medication can possibly work for them, I say, why not try it? So in that scenario, I'm all in to support whoever wants to try it. I don't necessarily think a doctor has to force that on a patient, but to maybe give them that as an option and look more into it to understand what is going on, because it is more than just this weight loss thing for lipedema patients. We have been on every diet that's ever been out there, and we've not had the experience that these women that I'm seeing are having with the pain reduction, with reduced nodules, with weight loss. I mean, they're having serious weight loss on top of it. So for me, it was hope, and it was something that I could discuss and learn more about.
Thank you for sharing it and saying it like nobody else could, Patty. And that's why you are a beacon of hope to so many, because you live it, you walk it, and you walk through it. And I know, Dr. Amron, that you are not just in the business of taking care of lipedema patients. We have seen your heart. We know you care. So I know the way Patty just conveyed her thoughts touched you as well.
Well, yeah, it did. And it's actually the comment that you made beforehand, and I don't show emotion always, but it really almost made me teary-eyed with things, because I'm talking here with you guys and hundreds of people are watching, and you said that so many people feel hopeless out there. And it really struck me because, and I live this every day, but I'm on the other side of things. And I really have a heart and I really care. But you're right. I don't have lipedema and don't know exactly what it's like to go through my whole life with lipedema. But I hear it all the time and it touches me. And what really got to me emotionally is, that you said that so many women feel hopeless out there with things. And, you're right. And a lot of the positivity of all this stuff is great. And we are in a wonderful place for increasing awareness, where I kind of feel like people are finally getting answers to things and answers to things their whole life, and their choices and options with things. But it's still there's people that do feel hopeless for a number of reasons. I think, let's be honest. I think the really advanced patients, the stage 4 lipolymphedema, it's not always the easiest thing, the easiest journey with things like that with it. It's not always these heroic, the stories that are just like so easy. That's one thing. There are patients that simply can't afford things with it, which is still, it breaks my heart with it. And, the insurance companies and this and that, and things are getting better, but it's still a battle with it. And when people put up GoFundMe pages and stuff like that with it, it's really, so there's definitely a lot of emotional components that go on with lipedema that still continue to go on. It's not like they found the answer to things and they do something, it's just taken care of. There's a lot of trauma that's gone on with it. So I am optimistic things are good and they're getting better. And I hope they continue to get better. And I've said this, I'm really protective of the community and I hope it comes across that way. And I want to try to all work together to do things the right way. And also to just try to guide so that people can have answers to things and in their journey make the right choices with things and think really carefully about decisions about things. So that's, but I don't want to say, I live this stuff every day with it. It's like, to me, it's not a job. Like I've said, it's a big part of my life. It's a huge part of my life with it. So
I am reading the comments in chat and people are saying thank you. Thank you, Dr. Amron, for being willing to answer anything we threw at you tonight. And we could have thrown a lot more. And you did it with grace and humility and curiosity. I was particularly struck when you asked the panel a question, should I be doing this with my patients? As long as we are curious, we are learning and we are growing. And as we are learning and growing, we're getting closer to providing hope and help for people. And look, I'm not into let's be Pollyanna and, let's end on a high note, because this has been some really deep talk tonight. But at the same time, we know that we all need encouragement in life because we need courage in life. At the very center of the word encouragement is the word courage. We want to leave all of you with some extra courage tonight. So if you could say one thing to our audience, what would it be, Jenny?
I think for me, it's about every day since my diagnosis just 4 years ago, the reminder that the reading, the understanding, the knowledge of everything that I've learned is powerful. And making tiny changes along the way over the past 4 years has made such a monumental change. But to remember above all, because this takes a lot of time, self-care takes a lot of time every day, but to remind yourself we're more than just the lipedema. Every day, remind yourself you're more than just the lipedema, and go out and enjoy and be and adapt if you need to, but do something to keep on going, because I think that makes all the difference. But it's all those little changes add up over time. Let me tell you, I'm proof of that.
That's so beautiful. You are more than just the lipedema. Angelique, what would you say?
Let's face it, lipedema sucks. Like, this journey is absolutely frustrating It is painful mentally, physically, and emotionally. And some of us have waited until our 30s, our 40s, our 50s. I heard from a lady in her 60s to get diagnosed with this. It has been a frustrating battle. But if we haven't learned anything else tonight, I think that we see very clearly that there are people out there that care about us. Dr. Amron, we really do appreciate your passion and your humility tonight, and actually just embracing what we're doing here in this roundtable and with this slew of patients here. And I think that that's a really good testament of where we're at. We've had Lindy Ann McCutcheons, Linda Ann Kahn, Dr. Karen Herbst, Dr. Amron. We have people who actually are researching and they are willing to push the envelope for us. So don't give up on you while these professionals are out here pushing for you.
Mm-hmm. Said Angelique. Pale ginger pear.
So my advice is two-part. One, as you see here tonight, you're not alone. There are tons of us, way more than there should be, in my opinion, because we should have gotten help years ago, but we are here. This condition has brought some of the best people into my life that I never would have met otherwise. And for that, I am forever grateful. But also, I advise everybody to not be afraid to be vocal, not to be afraid to bitch, and not just to doctors. Let your friends and family know that you're in pain. I know for years I did everything I could to hide how much pain and how bad my mobility was, because I didn't want to be that burden of a friend. I didn't want to be that fat friend that was lagging the group behind. I wanted to fit in. So I tried so hard. And if you look back at any of my beginning Instagram pictures or my first interview with Brenda, you will see the resting bitch face as I was trying to hide the pain and the misery that I was going through, because I didn't want that judgment of, well, you're just fat and lazy, lose weight, and you wouldn't be that way, when I knew there was something else wrong. And every single doctor appointment, every therapy appointment, every nail appointment, every eyelash extension appointment, hair appointment, I tell everybody about the condition because they're in the position to talk to other women. And even if your friend group doesn't have another lipedema lady, their girlfriend might, their mother might, their aunt, their daughter's teacher might, like somebody in their life. If there's 1 in 10 or 1 in 9 of us, you're going to come across it, and you're helping them branch out with the information. And so be vocal. Don't suffer in silence. Like, if they're your support, they're going to want to be able to help you. And if they don't, then that's not the support group you need. That's my little.
Well said. And when you said the fat friend, anybody would be honored to just be your friend. And we are honored that you are our
I don't
friend.
think fat is bad now. I use it all the time to describe
No,
myself.
I know. I listen.
But
I was pulling this photo of me when I was 5 years old up, and and I was 100 pounds in kindergarten. So I remember what it was like to be fat, and I just appreciate you. Patty, and then Dr. Amron for final words. Patty, go for it.
So the thing that came up for me today is finding glimmers. Glimmers are the opposite of triggers. They're things that make you sigh in enjoyment. Seeing your cat, seeing a beautiful sunset, having the sun on your face, just little moments that make you feel good. And it's a psychological thing. It's not just a physical thing. So I'm looking more for those and honoring them when they happen. And if I bring them more into my awareness and not just like, ooh, pretty sunset, but I take a moment with it, they build up throughout the day, and it really does go a long way.
We're going for the glimmers, not the triggers in this coming month. I love it. And Dr. Amron, would you honor us with some final words to encourage our audience? And thank you for letting us go.
Yeah.
We never do this, but we had to tonight.
So yeah, some nice positive things to end. So I'd say that someone else just said it. I think, transcending, you're not lipedema. I mean, yes, it sucks. You've got this condition, but that's not you. You're so much more than that. And just transcending, I think, transcending, we don't define ourselves by any one particular thing. We look to transcend many things in our lives and transcend even hardships with things and look past it. That's one thing. I think the other thing is that I've also always said in my life is that, happiness, and I've said happiness comes as a byproduct of the way in which we live our lives. It's many times we try to be happy, happy, we're looking within for that happiness. But, as much as we can try to look outside, it's the way in which we live our lives and what we do for other people and the good we do in our life. We kind of get out of our own heads with it. And happiness just happens, becomes bestowed upon us. So I just say to everybody, just continue to be out there, and live this life to its fullest and do your best to help others, be good to others. Try not to focus, on ourselves too much, because we get wrapped up in our own heads with things like that. It's not all so good. And then we find ourselves in a happier place by just the way in which we live our lives.
Beautifully said. Thank you again, Dr. Amron. You've been more than generous with your time tonight. Thank you for leaving us with all that positivity, everyone. And let's look for the glimmers in this next month. We will be back. We'll see you in September at the Lipedema Patient Roundtable. And we hope we can have you back again sometime, Dr. Amron, because we really enjoyed having you.
How do I do that?
Everyone.
How do I do
I hope you feel the love, everybody. I hope you feel it because we mean it. You have a great night, everyone.